Good afternoon, everyone, and thank you for joining us today. We are going to give folks another minute to log in, and then we'll get started. Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's presentation, Integrated Care 101, Overview and Best Practices within Youth Serving Organizations. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. Once again, thank you for joining us. We are pleased to be joined by Michelle Dupre, Director of Integrated Healthcare at Starfish Family Services. I'll now pass it along to Ms. Dupre to introduce herself and get us started.
Thank you, Jason. Hi, everyone. Welcome. Good afternoon. Sunny here in Michigan, so we're happy about that. Get a little vitamin D. I'm really excited to talk with you today about integrated healthcare and hopefully get you excited as I am about it, but also curious about different ways that your organization or you might be able to be involved. Even if you can't do the full kind of model, getting some ideas today that might help you put your toe in the water, so to speak. So welcome. And as Jason mentioned, my name is Michelle Dupre. I'm the Director of Integrated Healthcare at Starfish Family Services. And we're located in Wayne County, Western Wayne County, in Inkster, Michigan, and we're a suburb of Detroit, Michigan. And so I will give you some information as we go along on some of the things we're doing, but also some ideas on some of the things, like I said, that hopefully you might be able to do as well. I start, it's not working. My page down isn't working.
You click on the screen.
There we go. Thank you. Easy fix. I start every webinar that I do with this slide. My dogs apologize in advance for any disruptions. They are sleeping right now. They're pretty well trained to know that when I'm sitting at the counter on my computer talking, that they should be quiet. But if anyone dares walk any close to my yard, Mr. Seamus there will probably bark. So just wanted to give you a heads up that they send their apologies in advance. So our agenda today, just to give you an idea of the overview and the flow, we're going to do an overview of pediatric integrated healthcare, the why, the what, and the how. We're going to talk a little bit about approaches to pediatric integrated healthcare, and that is these three general options: integrated, bidirectional, and what I've determined, kind of called as basic. Basic is still fantastic. It's getting your toe wet in the water there. And I think what's really important to think about as you're hearing the presentation today is, as you know, pediatric integrated healthcare isn't new necessarily, but it's become more talked about, more popular, more studies, more articles. And what happens is, even though that's fantastic and that's great and we want that, what tends to happen sometimes from that is some level of confusion as well. So the market gets a little confused as far as, well, this article says this or defines this way. And it can really leave people feeling like, well, I don't really even know what direction to take. So with that in mind, I'm going to try to simplify a lot of different complicated things so that you can, my hope is at the very least, you'll walk away today with a general understanding of what integrated healthcare is, these approaches, and have a level of understanding that feels organized in some way, shape, or form. And then I talk about some examples of this basic integrated healthcare for specifically mental health providers. So I'm going to go into a little bit more examples of how that can be done and what we're doing at Starfish Family Services. So we have a poll. Does your organization currently have an integrated care plan or services? A for yes, B for no, C, what is integrated healthcare? No shame in picking C, that's not a problem. It's really important that we know kind of where people are at. Okay. Looks like we have our results. 18 yes, 9 no, 12 what is integrated healthcare, and 33 not sure any of those answers fit. So that is helpful still to know where some people are landing. Thank you so much. Okay. So integrated healthcare is really, as I mentioned, it's not new. It's not even a concept anymore. It is a way of delivering care and doing business. And it's been around in a variety of different ways. The Veterans Administration has been doing integrated healthcare for 25, 30 years. It started in general in pediatrics, which is fantastic. And since then, there's been many different iterations and definitions of integrated healthcare. But it is a way of delivering care. But again, most people kind of get to this point where they say, okay, well, what does that mean exactly? And so what I start with is, well, let's first think about why. Why are we focusing specifically on pediatrics? I don't know if you've had this experience or not, but in my work, there's a lot of models that are developed for adults. And I'm usually the one at the table saying, how about pediatrics? And it's kind of like, oh, an afterthought sometimes, like, oh, well, just modify this model, it'll work for kids. And I think you may agree that that's not really appropriate, because we know that children are not little adults. There are specific risks in childhood that need to be addressed, that need to be part of plans, need to be part of models. So hopefully you know that adverse childhood experiences study, extremely, extremely important, especially in the community of integrated healthcare in pediatrics, because it truly showed that distinct connection between what happens in childhood and the physical health impacts later on in adulthood. There was a clear line there, drawn and bolded, if you will. Again, children have developmental risks. They have, the autism spectrum disorder, cerebral palsy, developmental disorders. They have health risks, especially as it relates to poverty, as it relates to clean water, as it relates to food deserts. There's a lot of many different aspects of health, thinking in terms specifically of the youth population, which sometimes is even less brought up when you're talking pediatrics. A lot of times you think pediatrics and you're thinking, the 3, 4, 5, 6-year-old, but the youth in our communities that have special developmental needs that need to be addressed in healthcare, sexual health, different things like smoking, eating disorders, drinking. These are all aspects of health that we can't ignore, but that are specifically risks to that child. Obviously, there's some systems that children are part of that adults are not necessarily part of. So the foster care system, the juvenile justice system, residential systems, lots of different things. School, school is the #1 job of a child, and that's a very different experience for a child than an adult having a work life. And then obviously the social determinants of health, getting a lot of talk, a lot of dedication to really identifying how where you live is directly impacting your health. And so children's health, where they don't really have that control over where they live, if they're in a food desert, if they have a safe place to play, if they have a safe school district, things like that, that's a special kind of risk for childhood. So in that sense, that's why really talking about pediatric integrated healthcare as integrated healthcare, because for adults it looks different. And obviously mental health is a specific risk for childhood. And from Child Stats, this is a little old, 2017, but I did look, and they're just real quick, they're pretty much the same. 6% of children ages 4 to 17 were reported to have serious difficulties with emotions and behaviors, and that's up 1% from 2015 is up 1% from 2014. So serious difficulties, that means that child is likely in the, would be served in the community mental health arena. But what about the other difficulties, the mild to moderate? Where might there be some allocation or some opportunity for prevention, for noticing these things earlier in order to not get to the point of having serious difficulties? So 6% of children is a pretty large number with serious difficulties. 12% of youth, so 12 to 17, again, that youth population I was talking about, reported major depression, major depressive episode. And if you know any adults, if you yourself have ever struggled with major depression as an adult, with your cognitions that are more at play, with your maturity levels higher, obviously, than a 12 or 17-year-old, you can imagine how difficult this is for a 12 to 17-year-old to deal with. That's 12%, that's a lot. And only 38% of those reporting said that they received any sort of treatment. So when you think of children, this is kind of the context I want you to be kind of landing in and kind of surrounding yourself with for a little bit. Unfortunately, in healthcare, what has happened is the silo. So we have physical health care, we have mental health care, and rarely the two shall cross. And what we found is that, when you think about these problems, these issues, these risks, they're identified, a lot of them, in childhood by the age of 14. So where do children go, and in some cases are required to go in order to get into a school, is pediatrician. So if all these children have to go to a pediatrician, but pediatricians are not really trained or have the time in a fee-for-service environment to address all of these issues, what happens? Essentially what happens is the silo. They get passed from the physical health silo into the mental health silo. How many of those parents make that jump is too little. It's not enough. And it's because we make it so difficult for them. It's because we have the silos that really we miss such an opportunity to intervene early and detect early. And so healthcare is operating in this silo world. When you think about 75% of children with diagnosed mental health disorders are seen in the primary care setting, that makes their management showing up in a place where social workers, psychologists, counselors, mental health professionals normally aren't at. We're sitting over here in our mental health world, waiting for the client to come to us. And that really hasn't worked in the history. So in a sense, as I mentioned, pediatricians, this is from an executive summary article that was written, again, 2009, but it's still relevant. Pediatricians are well positioned to detect problems in the child's social and emotional development because they're present in that child's life. They have a pediatrician they usually go to. Pediatricians, though, are like, I want to do stuff, I can't. I got 15 minutes to deal with all the physical healthcare things that need to be taken care of. It's so hard to also address these social and emotional developmental needs or mental health needs when I have to move on. And they feel so frustrated by that because they know that when they give someone a card that says, call this place, the most of them don't. And so it's hard on everybody. It's hard on the parent, hard on the pediatrician, and hard on the child. So why do we do pediatric integrated healthcare? It should be pretty clear here. We know that children eventually become adults, right? And children with these undetected physical and behavioral healthcare needs will likely become adults with more extensive and expensive physical and behavioral healthcare needs. That's why we are basically saying the silos are a problem. We need to cut those down. If children are in the pediatric office, then mental health professionals should be there with them as well. So what is this as we're talking about integrated healthcare? And this is where, again, I'm hoping to help muddle through some of the confusion and provide you with this pathway to understand these different layers and to recognize if there's areas that you or your organization can participate in integrated healthcare through this more basic understanding of what these are. So fully integrated is where a full-time behavioral health consultant, so that's a psychologist, social worker, counselor, master's level license, is embedded in the medical clinic. So they literally spend 5 days a week, one full-time equivalent in a medical clinic, and they co-manage clients, patients, normally with a more mild to moderate need, in partnership with that medical team. So that is full embedding, that's full integrated. And I'll talk a little bit more detailed about that. Co-located, this is what in general that means. That means a mental health provider. So usually it's a community mental health provider or a group, a mental health therapist that's with a group perhaps, but primarily it's community mental health. They station a behavioral health staff in the office of that medical clinic. So they're not integrated. They're in the same space. They're in the same building. They might even be in the same inside the clinic walls, but they're there to do their normal therapist job just within, but they're in the clinic. So obviously that helps. That's very, very an important step in becoming integrated. Co-located, for some people, that's all they can do. And that's fantastic, actually, because it allows for that behavioral health person, that mental health therapist, to work directly with the patients in the clinic. They just aren't embedded in that clinic. They aren't kind of working there like an employee necessarily. And the records are different and things like that, but it's a good option. Bi-directional integrated healthcare is when you primarily are offering a mental health service. So you might be a community mental health provider, a mental health clinic, and your clientele, their highest need is mental health services. They also have some comorbid issues that they could utilize physical health care within the behavioral health setting now. So this is where you would contract with maybe a federally qualified health center, private practice, nurse practitioner, and you ask them to come to your mental health clinic to provide some basic physical health care within that mental health clinic. So you'd kind of look at it as the patient's medical home is primarily your mental health facility. That's their highest need, but they do have some things that need to be participating in some physical health care and they're not getting it otherwise. Or they're getting it and you're not able to collaborate with that physician. So bi-directional can be very helpful when you have a large population, mental health as the focus, but there are some physical healthcare needs of your patients. That is bi-directional care, where you bring a nurse or a doctor into your mental health facility. And then basic is something I've kind of made up for the presentation today, which is less than these options, but it still can be transformational. Something is better than nothing. There are things you can do, and there's some examples I can give you, that you can do that's integrated healthcare related, but it's not integrated, it's not co-located, and it's not bi-directional. So we'll spend probably a little more time on the basic part because I think that'll be most helpful. Did I see a chat question? It kind of popped up. Does a co-located practitioner pay rent to the medical office? That's a great question. So there are many models for integrated when you are there. In general, no. In general, when there's no money exchanged when you're doing co-located care, what you're doing is your service, it's just in that location. And what the benefit is to the physician is you are right there. They can literally have the patient go right to you, and you're there in the sense of you can collaborate on care, coordinate care, speak with each other. And most of the time, physicians, what they get out of that is somewhat of a partner in their care. I'm not saying people don't charge rent, maybe they do. I'll get to the billing at the end, so we'll hold on to that one. But in general, it's a partnership that's done through a memorandum of understanding, and you agree to exchange services, essentially. So integrated healthcare. So this is that first model. This is the one that my department does. So this is the full model where primary care and behavioral health are provided together, same site, they're part of the same team. I never see my staff, rarely, because they spend 40 hours a week in a medical clinic. They treat patients together, side by side, shoulder to shoulder. They usually have one treatment plan. My staff are in the medical record of the clinic. And those clients that my staff see are not clients of my organization, they're clients of the medical clinic. They make referrals, they do lots of different things that really help the patients primarily, but also help the physicians. So my behavioral health consultants, they consult the primary care doctor, they also provide them with information, they assist with assessment, management, psychological health, focused interventions, skill training, resources. They're not doing traditional therapy. They are doing, and what I call assessment is not a psychosocial. It is a more of a functional assessment. So what's the problem today? What's going on right now? The role of the specialty therapist, so where we refer to somebody, that needs actual therapy, we need you to provide still that therapy. So we're not taking over any sort of therapy work. We're basically doing brief, focused, evidence-based intervention for mild to moderate. If we can keep a client in the primary care office and provide them with some mental health intervention, we want to do that. It's better for the patient and it's better for the physician to have that care coordination. Not all children need therapy, but when they need therapy, we have to be able to connect them to a community mental health organization in order to get that therapy. And then we can provide some care coordination once that occurs. What we do is, again, we're embedded, we're part of the team. We talk about mental health, but also health behaviors. So in other words, my behavioral health consultants they can't be psychiatrists, but they do need to know basic medications for their population. They need to know that a certain medication causes a tummy ache for a child. They need to know, they don't have to be nutritionists, they can't be, but they do need to be able to kind of talk about that you can have cauliflower instead if you don't like broccoli. So we do talk about health behaviors. A really great example is asthma and the connection between asthma and anxiety, which I'm going to use as an example later for basic. Usually this type of setting is the best case scenario. Unfortunately, billing has not caught up to this model, especially in pediatrics. And so one of the things I'm doing is I'm an advocate to try to move this forward and get true integrated healthcare to be sustainable through billing. Mostly it's by grants. So I have to keep clicking here. Okay, co-located care then is where mental health provider, as I mentioned, partners with a medical clinic. They generally assign a therapist. They work part-time maybe or full-time in that clinic space. No money is exchanged. It's just a memorandum of understanding that says, here's what the clinic's going to do. Here's what the mental health provider is going to do. The therapist can set up a workflow with the medical clinic to kind of receive referrals. So it can be a warm handoff to this therapist. If the physician is asking for therapy, the therapist is right there to accept those referrals and see that patient right in that medical clinic. The therapist, again, is very helpful because it's a quick resource for that medical team. It is kind of a partnership still, maybe not side by side, but it's still beneficial. Being in that close proximity, I think, to the medical team is really what helps with that care coordination, as well as communication. And that helps both sides. That helps the physician and the therapist. If you're a therapist and you've tried to reach out to a pediatrician and had a really hard time with it, I know what that's like. This is a way to really just ups that communication in a way that's really fantastic for the client as well. Basically, a therapist is free to kind of create a more solid relationship even with that medical team, attending their meetings, going to their events, participating in their lunches, and really ingratiating themselves into that group of professionals and becoming more of a partner based on their effort to do that. And that, again, can be very helpful all around for the pediatrician, the therapist, and the patient. Bidirectional care, as I mentioned, is much more difficult. I'll be honest with you. It's not as successful for a lot of places that have tried it. It is possible to be successful, but it is much more difficult than fully integrated or co-located. And the reason for that is because of volume, because it's difficult to have the volume needed to pay for this level of care. So participating with or partnering with a federally qualified health center in your area might be the way to go. But it's essentially where, as I mentioned, physical healthcare services are provided within that mental health clinic. Again, usually community mental health, and the level of care that this is usually done is with that severely emotionally disturbed population for children and the severely mentally ill population with adults. Where we see this most helpful is with adults. The volume is there. With children, it can be a little different because a lot of children, the parents say, I really like my pediatrician and I don't really want to get these services from my mental health clinic. There's really a connection, I think, between parents and pediatricians. It might be a little different for adults with their primary care doctor. As I mentioned, the best way I've seen this work is when it is a community mental health provider partnering with a federally qualified health center. This primary goal, though, of this model is to really improve this overall health of your clients by providing them, again, with that collaboration, that purposeful intervention, and that concept of connecting health behaviors with behavioral health. So are you depressed because you're overweight, or are you overweight because you're depressed? And really helping even do some psychosocial education with families, with children, with parents, with adults, to kind of talk about that connection between your mental health and your physical health, and how you can't, cut off your head and serve your body and your head in different ways. That health is health. And that's really the goal of all of integrated healthcare. And it really does, in this sense, for this particular population, it does help, this breaking down of the silos, because you really do get some folks that, especially again in the adult population, who aren't doing both. They aren't doing physical health care and mental health. They really have the resources a lot of times to just focus on one. And so we really need to be there in both arenas in order to really affect the outcome of their healthcare outcomes. And again, it's difficult to financially support due to the cost of the physical healthcare providers, their ability to bill, creating your mental health site as a billable location for their billing. And again, the volume has to be there in order for it to be not a money loser. You're likely not going to make money off integrated healthcare, but obviously the goal is to not lose a lot. You might lose a little. You can't lose a lot. Most organizations can't lose a lot. Okay, so here's kind of the part where I'd like to spend probably the most time just talking about, okay, as you're thinking about this, where could I fit? Where could my organization do something if I can't do these other things? And so the transformation aspect of this, what I'd like you to do is, as we're kind of talking about this, picture yourself doing some of these, or the possibility of perhaps doing some of these things, and how transformational could that be to your work and to your clients. And it might generate some ideas. And actually, if you want to jot down some ideas, I'd love at the end to kind of have you share those, because I'm just one brain, when you do the synergy of all of our brains together, we've probably come up with some other great ideas besides what I have here. So when you're thinking about what can we do, I can give you an example of a possible opportunity as it relates to funding. If you're in a community mental health organization, you want to try to see if you have a block grant, a federal systems of care block grant. What we have done in Detroit Wayne Integrated Health Network is they have a systems of care block grant, and there's many different programs that are run out of that block grant. But they added, and we're the providers for it, a pediatric behavioral health consultant within their block grant, their systems of care. And we were able to provide and continue to provide one behavioral health consultant. So that top level, they're doing integrated healthcare, and they're primarily doing it in the community where the community mental health is located, so central Detroit. And we found 2 clinics, health systems, and my behavioral health consultant is working within those 2 clinics. So 2 days one place, 3 days another place. And really, because they're part of the community mental health systems of care block grant, a lot of the work that they're doing is to work with children that are in community mental health. So there's a big population in this particular area that are using or qualify for community mental health services. And by having this behavioral health consultant in these clinics, they're able to really make appropriate referrals to community mental health and not clog up the referral system with clients that don't qualify or shouldn't be in CMH. They get those clients into different, maybe their Medicaid health plan for some therapy, or they keep them. My behavioral health consultant will keep that client who's pretty mild and keep them and do some intervention with them in that medical clinic. So this is funded by the federal system, the systems of care through a block grant. Most CMHs, I believe, either have a block grant already or could get one. And that's one of the ways that we're able to provide pediatric integrated healthcare in these 2 particular clinics. On our own at Starfish, we, again, are a community mental health provider, and we have case management services. And they're traditional case management, what you would normally bill for case management. But we saw a need for somebody to really focus on particular physical health care for children in community mental health, asthma, obesity, and diabetes. And so what we did is we added a medical care coordinator to our case management team who got some specialized training in understanding what's asthma, how obesity works, what's diabetes. And any client that was identified as having any of those diagnoses, instead of going to our general case management, went to the medical care coordinator who was doing case management specifically for the medical piece. Obviously, within CMH, there's certain rules you have to abide by in order to open a case management case. So we did have that barrier. But this person was the go-to person for the case managers, the therapists, and the clients to talk specifically about their medical condition and to coordinate very, very specifically with their physician. That we found was a huge game changer in the ability to partner with whoever the doctor is. So in this case, my medical care coordinator could talk to any doctor, even go to visits with the patient sometimes. So that's a basic kind of strategy, but it certainly is something that can be very transformational and has been very transformational for the clients that we've served through this idea. So another option, I don't know if you've heard of this before, it's taken off probably in the last 5 to 6 years, is, as I was mentioning about this medical care coordinator, there's been this push through SAMHSA and the National Council about really trying to get all case managers to move from a traditional case management training and mindset related just to linking, coordinating referrals, things like that, and facilitating resources for patients, but also to start doing more care management. So moving a little bit from case management to care management, and that is kind of a retraining to try to help staff get that knowledge and that skill level to take that care coordination approach, especially for medical needs. And so this is a training that's been offered for a couple of years. It is an investment, there is a cost to it, but when full community mental health organizations or full providers come together to train all of their staff, it generally has a pretty big impact on how to move a little bit away from traditional case management and start getting a little bit more into that integrated space, because you're starting to integrate that medical piece for patients into the work that you're doing in mental health. So I'll give you a little, an example of the case to care management training and how to get that. But that is another example of something you can do as a mental health provider. And then finally, something that we've also done with our community mental health is we created the community mental health organization agency created an integrated healthcare work group. So our community mental health, I said it's an authority, actually, not an agency. So the authority in our county created this integrated healthcare work group for pediatric providers. So all providers of pediatric community mental health came together, and usually it's a manager, director level, kind of somebody in a decision-making capacity. They all came together. So we had, I think, 15 or 16 folks, and they really came together to kind of create a system-oriented initiative and to address this population health issue in the community. So your community might look different. Our community, our population that we're focusing on is obesity and asthma right now, that we find that for our community mental health kids, those two physical health diagnoses seem to be the most prevalent. And so that's our population. That doesn't mean we're not going to do other things, but we're starting out with this idea that our population is any community mental health child who has obesity or asthma. That becomes who our focus is. So we've come together to kind of say, how do we want to treat them within the barriers and confines and silos that we do have to deal with realistically. And so bringing all this synergy together, everybody's mind, everybody kind of saying some ideas. Yes, I could do that. No, I don't think we could do that, but we could do this instead. We also have a medical provider on our team as well that can really kind of answer some things that we might say, well, we think a doctor should do, blankety blank. And the medical person goes, no, it's not going to happen, but we can do, I think providers will be able to do this. So it's really important to have kind of both sides. And so essentially what you're doing is you're again, dipping your toe in the concept of integrated healthcare in a way that you can do it, and getting people started and energized and curious about what else can be done by bringing together this focus group. And we meet once a month, once every other month, depending on what's going on. And we kind of are creating, one of the things we've created are some specialized training for our clinical staff. When I went to school, a social work school, I got nothing on medical. I walked out of there very well trained in being a social worker. But I remember way back in the day when somebody asked, about medical stuff, it's like, well, I'm not a doctor, I'm a social worker. That's what they're supposed to be doing. And doctors are saying, well, I'm not a social worker, I'm a doctor. That's what they're supposed to be doing. So this, in a way, is a sense of kind of pulling those two silos a lot closer together and providing the reality of the situation, which is you don't have to be a doctor to talk about asthma. You don't have to be a nutritionist to talk about food, but you do need extra or additional training and support, not just going and saying, hey, start talking about nutrition, because you'll get, a lot of us mental health providers are kind of say like, I've got a lot to do already, and that's a lot more to add. But what you find is being able to integrate those conversations in your normal conversations with clients can be extremely helpful, not only for the client feeling like you understand what's happening in their life, but also not putting the parent in the middle between their mental health provider and their physical health provider. Essentially, if we don't make that bridge, the parent is the bridge. And A, that's stressful. B, you don't get a lot of appropriate kind of care, because that's not what parents are there for. So we want to be the ones to create that bridge between the mental health and the physical health. So I'm going to give you some example. As I mentioned, from Wayne County, this is what we're doing. We have this work group. It's hosted by the community mental health. We have all children's providers are invited, usually management or above. We talk about healthcare issues within our how the children that we're serving. We came up with these decisions of how to address these main issues that we found: asthma, obesity, and diabetes. We formulated some responses as it relates to resources, some training and recommendations for clinical staff on how to address these three issues with support. And we're trying to create a consistency among a large number of providers. So it's not just one provider is doing it, but the other one isn't. You know, it's really about this system of care, which the system is mental health providers, and the care is about increasing or upping our care to include the physical and the physical health aspects, but not in a way that's overwhelming. We want it to keep it in a way that's helpful and that makes me as the mental health provider feel adequate in my service that I'm providing, that I'm able to talk about some of these things. Obviously, again, you're not treating the asthma, but you want to be able to say and talk about how asthma and anxiety are related. It's just that kind of level. So this is just a letter, an example for you to see of what the Pediatric Integrated Healthcare Work Group put out to all of the providers, because there's not all of them were on this team. Some of them just weren't able to do it. But we basically said, this is what we're doing. We believe that when physical health providers are more informed about mental health, and when mental health providers are more informed about physical health, the consumer receives better care. This is our mantra. So we're really introducing to everybody what we believe in, what we want to do. We're creating this initiative to kind of help with this. And this is a perfect example of how we passed on to all the providers a basic asthma video. It's from the American Heart Association. It's a basic video on what asthma is. You can get a little certificate at the end, and you take a little easy quiz. This is an example of what our work group came up with in order to help provide a training about asthma. So I just wanted to show you this as an example of how we were able to kind of pull together and create something that everyone, we wanted to let everybody know about, and it created a resource for people. So some other examples of what we've done. We have an asthma flyer that was created. I'm going to be really honest with you. I didn't write this. It's way too wordy. So don't copy it exactly. I would not make it this wordy, but it's still a resource. I thought you might want to see it anyway. But we created a flyer for staff and community family members of the client receiving mental health services that describes asthma, some causes, some diagnosis, trying to connect the child's possible experience of asthma to their mental health or social emotional development, how to kind of, you know, bring through this connection to anxiety, and being able to kind of, again, we're not expecting a therapist to be a physician, but we really think it's helpful for if a mental health professional is like, oh, you have asthma, what's happening with that? How is that controlled? I want them to have that knowledge of what controlled means, or have that knowledge of what uncontrolled means, be able to talk about that and be able to guide the parent to getting an asthma action plan at a pediatrician's office. If you didn't have that information, you might not know that that's an action step. So you can't read it very well, probably. I certainly can figure out some way to get it to you so you can see it a lot better. This was just kind of a print screen, way too wordy. But you can see it says, what is childhood asthma? What are some causes of asthma? How do you diagnose and treat asthma? What are kids' feelings about asthma? Some anxiety disorders, what is childhood anxiety? And kind of helping make that bridge between, is it a panic attack or an asthma attack? So really just kind of creating this resource for families and therapists. We also have at our community mental health complex case management program. And again, that's just a extra, if you have complex medical needs and complex social emotional mental health needs, this is a level of care through our community mental health that really does, you know, would be much more for that higher level. And it truly is about doing very targeted case management coordination for those patients. So this would be kind of an example of that higher level of integrated healthcare as it relates to these high physical health and high mental health needs. So there's a case to care management training, as I mentioned earlier. It's that integrated healthcare landscape training. You learn, you're using the same skills that you have as a case manager, but you're just increasing your knowledge, essentially. You can be more active in the client's medical need area, whatever that might be. It provides this kind of broad case management with this added focus of physical health care, and you get the skills and the knowledge in order to do that. And basically, you're not getting trained to cover every single possible medical diagnosis. It's really just the concepts and the knowledge of how to use your skills a little bit differently to move from case management to more care coordination, care management. So again, not expecting you to read all of this. I just wanted to give you an example. It's done through the National Council. You can sign up your organization for it. You can get more information about how they can come to you with the training. And that's essentially most of the time how they do it. You have a big organization, they develop the training with you, and they come to you to do one presentation or two presentations to everyone all at one time. So it's pretty efficient, I think, as an opportunity to raise the level from case to care training. So to finalize here, I'm at 145. Best practices and recommendations in this kind of basic model. You want to assess your existing service gaps in the population you serve. The population I serve may not be the exact population you serve. You might have more substance use among your youth. You might have, and that might be a chosen population for you to address. You might have different physical health care things that are happening or social determinants of health in your community. So really you want to assess what are your service gaps for these things that you've seen in the work that you do. We as social workers, counselors, psychologists working in mental health, we see a lot and we know what the gaps are. So you want to assess that really very specifically. Use those findings to create a focused population, as I mentioned, children with mental health diagnosis and blank. Maybe it's obesity, maybe it's ADHD, maybe it's asthma, maybe it's something else. If you can create a group of staff who can pull together resources to address that population, you're doing integrated healthcare. It's not that high level integrated health where you're in a doctor's office, but you are doing integrated healthcare. If you can develop a needs assessment for that focused population to really drill down, to really get into the details of what's going on, what that client population needs from you as it relates to their health, that is a really good way to get started and focused on just picking one thing first. And that would be my recommendation. Don't try to do it all at once. One population at a time. You can use that group to brainstorm, develop possible and probable interventions. That might be training. You might have to up your psychoeducation, and that might make your transformation. What will make a really big difference to your mental health services and to your population? And it might be something even more creative than what we're doing in Wayne County, which I think would be fantastic. And then finally, you want to leverage the leaders who are part of this group to make structural or programmatic changes in order to be successful. You need some people. I know in mental health, we can have some great ideas. Therapists, we're at the ground, case managers, we're right there at the ground level. We come up with great ideas. But if we can't get that kind of buy-in from our leaders, it tends to not go anywhere and we get frustrated. So we'd really want to start with a best practice recommendation would be to get at least one or two champions on this team that can really make some decisions and have that ability to make change. And I think that's it.
Great. Thank you so much for such an in-depth presentation. And we did have a few questions come in that we wanted to really get your thoughts on. So the first of which is, can you talk about the lessons learned from the work group or any struggles that you've encountered?
Yes. I don't want to take up all the time on that, but I'm a realist. And yes, there are barriers. What tends to happen is when the group comes up with a great innovative idea, you get a couple of folks that aren't seeing, they're representing their own organization and what they can and cannot do, versus seeing this group as a way of creating something new together. And so that's been a barrier at times to try to overcome and remind people. There are ways we can be creative. Yes, there are rules in community mental health. There are billing issues, but what will really help your efficiency? What might help your client reach these goals that you have for them? you're really spinning your wheels if you just keep doing the same thing over and over again and then saying our outcomes aren't very good, or we keep getting these emergency visits for a number, our clients keep ending up in the ER with what they think is an asthma attack. It's really an anxiety attack. So it really is challenging everyone. Yes, you have to represent your own organization, but at the same time, you're creating something new, and to not get stuck in just, well, we've never done that before. That's not how we do things. How you do things is what you're coming together. The new way of doing something is the reason you're coming together.
Great, thank you. And a follow-up question to that was, do you have any written standards of care that you encourage members of the work group to abide by?
Oh, that's a great question. We really don't. I think that would be, I would say that's a step that we missed when we developed this group, because we weren't sure at the time what it was going to look like. So in hindsight, I think we should have done that. We should have come together and made some affirmations with each other, made some standards together, and made a mission statement. We did do that later on, but we probably should have done that at the beginning, and really kind of made some standards. And the other thing that can come out of this group is advocacy. So we all sat around and talked about the problems and the barriers with case management billing. And a lot of my medical care coordinator couldn't do a lot of things with patients because he's billing traditional case management, but what he's doing is different than traditional case management. So as a group, when we all talked about that, that becomes an advocacy. So we started collecting some data. We started collecting some stories of people who needed that service but couldn't get it, and trying to advocate to the higher ups and even to the state of Michigan about the barriers that we're having in doing some of this work. We still did the best we could, and we still did the work. There were quite a few situations where we did not make the billable numbers that we wanted to make, though. That would be a good idea. The coming together to make the standards is a great idea.
Awesome. There was a question about the term resource mapping that one of our participants has heard of, and they're wondering, would you recommend it for organizations that are looking to extend their services?
Resource mapping? I don't know that if whoever asked can give me an example of what they mean. Maybe I'm thinking of it, I know of it, but as a different name. I don't want to speak on something that is different than what they're asking.
No, they're specifically talking about really going out into the community as a behavioral health organization and really assessing what other services are out there.
Oh.
To build up a system of referrals.
Oh, yeah, absolutely. So I have a care coordinator. We also have nurse family partnership on my team. And it's paid for by that program. So she's able to do so much. Her main job is mapping resources, not just getting the name and what they do, talking to the person, making the connection with somebody there, getting to know their name, sharing, having a relationship with them, and really taking deep dives into that. I think being able to care coordinate with any resource in the community is really contingent upon your ability to form a relationship with them. Even if you can't get a formal partnership or a memorandum of understanding, a relationship between your care coordinator or your case manager and that referral source, highly, highly worth the extra work it can take.
Great, thank you. Another question that came in is, how would you recommend talking through the relationship between physical and mental health with youth and families? Specifically, this provider is saying that they're often met with some looks of confusion as to why the families are being asked these questions.
Yes, and that happens in the physical health environment as well. So I'll just give you a real short example, that when a pediatrician would say, I'm going to bring in the social worker, the parent would freak out because they envision protective services. So we had to train all of our physicians to describe us as their partner, and that no matter what the family says their need is, the physician says, oh, I have someone for that. Her name is Michelle. I'm going to call her in. Is that okay with you? That's her expertise. She's my partner. That automatically provides a level of care and safety for patients and trust. So I would really, if you're able to generate this, a similar type of response is really what you're looking for. So you want to come up with a metaphor or an example of how frustrating it has been. You know, it's probably been super frustrating for that parent, and we know it's frustrating for other families when they bounce around like a ping pong ball or like a pinball machine, where go to the doctor, no, go to the therapist, no, go to this resource, no, go to that resource. That really what you're trying to help them with is to recognize that health is health. Whether it's mental health, physical health, doesn't matter. Health is health. And that's why we ask these questions, because we know that stress can come out physically in someone in really difficult and scary ways sometimes. You have a lot of headaches. You might be thinking, the worst, but it might be really stress. Really making an example. Some people really get scared about the adverse childhood experiences discussion, and I don't blame them. But I always start with this basic concept of health is health. And I always start, especially if I'm sensing that someone is uncomfortable, just use the word stress. Stress is a relatively common word. Everybody knows what stress is. You don't even have to say anything about depression, anxiety, or anything else. If you start with the word stress, that it affects your body, you tighten up, you get stomach aches, headaches, that's a really great inroads to helping with both mental health and physical health. Keep it kind of basic or generic with just the word stress.
That's perfect. And we often do get questions like that, in terms of psychoeducation, really relating to and engaging with youth and families. So thank you.
Yeah.
And another question that we did have is for individual providers who really want to advocate for an integrated care model at their organization. How would you recommend they approach that conversation?
Oh, there's many ways. If you want any resources, studies, papers, videos, they're out there on Google. You just Google it. There's all kinds of stuff on YouTube. If you are a mental health provider for severely emotionally disturbed children and/or SMI adults, definitely watch the video from Dr. Nadine Burke-Harris. You can Google it, it's on YouTube. There's a short version, I think like 7 minutes, and then there's a longer version, I think like 30 minutes. That makes the case, in my opinion. That's the quickest, easiest way to say, please watch this. This is why we need to do integrated healthcare. It's really about ACEs and trauma and pediatrics and the work that we're doing with children who have severe emotional disturbance. There are other kind of workforce development certificate programs out there. Full disclosure, I am the director of one at the University of Michigan, so just want to fully, report that, my disclosure of that. That can be a starting point for a lot of people to really get into the nitty-gritty of what integrated healthcare is and how it can be done and why it's important and all of that. And again, I think that addressing the conversation is really talking about, I'll just give you a tip of what I do when I present to physicians, right? So I go into a new clinic that's shown some interest, and I ask, my first powerful question I ask them is, how much time do you spend talking to your patients about something other than medical care? And they kind of are like, oh my gosh, like sometimes more, I get 15 minutes, I'm in there sometimes 30, 45. What happens as a result of that? I get behind, I'm rushed, people don't get the service I want them to get. Great. What would happen if you could just pass that client off to a partner of yours after minute 8? Oh my gosh, this would happen, that would happen, this would happen. So those are powerful questions that are experientially based. If you're going to your administration, find an experiential example of maybe outcomes that aren't being reached because patients are not getting physical health care, because you're not integrated, because you're not partnered with physical health. Find something that is a fact as it relates to your client experience that people have social determinants of health needs. They can't get to mental health and physical health, so they give up one. And what does that do to your work? What does that do to the outcomes? That's your case. Well, we could address this if we were integrated, if we are partnered with physical health, or if we brought physical health into our environment. So find something meaningful, that's real, make it experiential, and create some powerful questions.
Thank you so much. And I think that's all that we have time for. We do want to take the opportunity to thank you, Mr. Dupre, for such an amazing presentation and for going in depth about your experiences.
Well, thank you. And we're going to provide everyone with my email address. So feel free to email me if you have specific questions. I will help as much as I possibly can. My goal is for integrated healthcare to be out there and be done. So let's get on board together, partner, see what we can do. And thank you again.
Perfect. And everyone, thank you for joining us today. I will say that we will share Ms. Dupre's email address. If you do have any follow-up questions, you can also check in with us at CTAC at ctac.info@nyu.edu, as well as visit our website, ctacny.org, to view past trainings, as well as to see the recording for this webinar within a few business days. I would also like to note that we do have a follow-up webinar on integrated care. It's Integrated Care 102, where we're going to be looking at a case example of cross-organization collaborative care, which is on Tuesday, March 9th. So until then, we wish you all well, and thank you for attending today's presentation.
Bye, everyone.
Bye.